Now we are going to discuss peptic ulcer disease. Peptic ulcer disease, as we know, is referred to as chronic mucosal ulceration involving the duodenum or stomach and is almost always associated with H. pylori infection, non-steroidal anti-inflammatory drugs, or cigarette smoking. So I repeat this definition once again that peptic ulcer disease is referred to as chronic mucosal ulceration involving the duodenum or stomach and is almost always associated with H. pylori infection or cigarette smoking or intake of non-steroidal anti-inflammatory drugs. Now when we talk of ulcer, and if you want to define ulcer, ulcer is a breach in mucosa involving the basement membrane. So ulcer is a breach in the mucosa involving the basement membrane. The most common cause of peptic ulcer disease is within the gastric antrum. The most common site for peptic ulcer disease is within the gastric antrum or duodenum due to chronic H. pylori infection. So the commonest site is the gastric antrum or duodenum. This causes antral gastritis where there is increased gastric acid secretion and decreased duodenal bicarbonate secretion. So there is antral gastritis due to increased gastric acid secretion and also there is decreased duodenal bicarbonate secretion. Now ectopic gastric mucosa seen in the duodenum, Meckel's diverticulum or esophagus secretes acid and can cause peptic ulcer disease. Peptic ulcer is also associated with cigarette smoking and in cardiovascular diseases which reduce mucosal blood flow leading to decreased oxygenation and delay the healing. So ectopic gastric mucosa in the duodenum, Meckel's diverticulum, esophagus, they secrete acid and can cause peptic ulcer disease. Peptic ulcer disease also associated with cigarette smoking and also seen in cardiovascular diseases because there is reduce in the mucosal blood flow leading to decreased oxygenation and ultimately delay the healing of the gastric mucosa. Peptic ulcer disease is common around the age of 60 because people take non-steroidal anti-inflammatory drugs. Their use is increased due to certain diseases and this is amplified by the presence of H. pylori infection which potentiate the effect of non-steroidal anti-inflammatory drugs and also responsible for inducing the gastric injury. Now here you can see these are the small shallow gastric ulcerations known as stress ulcers seen under stressful conditions like trauma, burn, sepsis and shock. This is a larger ulcer, gastric ulcer, which is about 3 to 4 centimeter in size and this leads to bleeding and responsible for the resection of the stomach. The ulcer, as you see in the photograph, is much deeper with irregular margins. Now, complications of gastric ulcer, they can be pain, they can be bleeding, There can be pain, there can be bleeding, there can be perforation and obstruction. Why obstruction? Because once there is ulceration, there is going to be healing, and ultimately there's going to be fibrosis, and after fibrosis there's going to be obstruction. There are many risk factors, and on the top of the list is H. pylori infection, smoking, alcohol intake, use of non-steroidal anti-inflammatory drugs, corticosteroid therapy, psychological stress, chronic obstructive pulmonary disease, Zollinger-Ellison syndrome, and viral infections like cytomegalovirus and herpes simplex virus. Now, in Zollinger-Ellison syndrome, peptic ulcer disease of stomach, duodenum, and jejunum can also be seen. And regarding psychological stress, a very important observation or point is that in stress or under stressful conditions, gastric acid secretion is increased. Peptic ulcer is the ulcer in the GIT, and this is due to the effect of acid peptic juice. It occurs in duodenum and stomach, and the ratio is 4:1. The proximal duodenum is the commonest site within a few centimeters of the pyloric valve, and mostly along the lesser curvature of the stomach in the antral or pre-pyloric region. So these are the sites that this is more commonly seen in the duodenum, few centimeters from the pyloric valve, and then along the lesser curvature of the stomach in the antral or pre-pyloric region. These are the commonest site of the peptic ulcer. Peptic ulcers, they are usually single, solitary, maybe of any size, maybe 1 to 7 centimeter in diameter or larger. They are round to oval in shape with sharply defined borders without any heaping of the epithelium surrounding the ulcer crater. Now, this is an important point. This differentiates between the malignant ulcers and the benign ulcers. Peptic ulcers, they are round to oval in shape with sharply defined borders without any heaping up of the epithelium surrounding the ulcer crater. Extension of the ulcer is limited by thick gastric muscularis propria. So its extension is limited, adherent pancreas, omental fat, or the liver. Now, as I told you that there is no heaping up of the epithelium, it means that the mucosa is at the level but may overhang the base, particularly on the proximal side. Whereas in malignant ulcer, the margins are heaped up. Regarding the pathogenesis of peptic ulcer disease or peptic ulcer, it is caused by imbalance between the gastroduodenal defense mechanism and gastric acid secretion combined with superimposed injury to the gastric mucosa from other factors. So one, there is imbalance between the defense mechanism and the production of the gastric juice or the gastric acid, along with superimposed injury to the gastric mucosa from other factors. Mucosal defense forces are: number one, surface mucus secretion, presence of bicarbonate in the mucus, epithelial regeneration, how quickly the epithelial regenerates, and prostaglandins. Now, the prostaglandins, they inhibit the gastric secretion, stimulate bicarbonate secretion, and increase gastric blood volume. So, prostaglandins, they perform these functions. Number one, They inhibit gastric secretion, increased bicarbonate secretion, and increase gastric acid volume. Ischemia, shock, and duodenal refluxes cause impaired defense mechanism. H. pylori secretes urease, proteases, phospholipases, and lipopolysaccharides, which attract neutrophils, resulting in inflammation. Platelet activation causes thrombi in small vessel, thus producing ischemia and ulceration. Non-steroidal anti-inflammatory drugs suppress the production of prostaglandins. Non-steroidal anti-inflammatory drugs suppress the production of prostaglandins. Smoking impairs healing and favors recurrence and also suppress mucosal prostaglandin synthesis. So, smoking impairs the healing and also suppress the mucosal prostaglandin synthesis. Clinical features: epigastric burning or epigastric pain, iron deficiency anemia. The pain occurs 1 to 3 hours after meals during the day, but worse at night, relieved by alkali or food, nausea, vomiting, weight loss, and when ulcer penetrates, the pain radiates to the back or to the chest. Complications: perforation of the ulcer in the abdominal cavity, which is a surgical emergency, severe hemorrhage or obstruction, as I told you that there is repeated healing and ultimately there is fibrosis and that leads to obstruction. Now, the larger vessels which are present in the scarred area, they are very thickened and become occasionally thrombosed. Now, this is the photograph which shows you chronic peptic ulcer or peptic ulcer disease. This is the ulcer. Now, again highlighted by red coloration, ulcer. Microscopic features. Now, spectrum of active necrosis to chronic inflammation to scarring. 4 zones of active ulcers. Number 1, zone of necrotic debris. Number 2 is inflammatory infiltrate. Neutrophils predominate. Active granulation tissue with mononuclear cells, especially at the base of the ulcer. Solid fibrous or collagenous scar. And there is a background of chronic gastritis which is frequently present. Now I show you the photograph of that. Necrotic debris, non-specific acute inflammation, granulation tissue and fibrosis. Now if you remember, take this word is dig. If you remember the word digs, D-I-G-S, digs. Digs, that is debris, which is necrotic debris. I stands for inflammation, G stands for granulation tissue, and S stands for scarring or fibrosis or scar formation. So if you remember this word digs, you can easily write down the 4 zones which are seen in peptic ulcer. Now here you can see there is necrosis and then beneath there is inflammation and beneath this there is necrotic, and look at these small blood vessels. There is granulation tissue formation, and down is the fibrosis, necrotic debris, and inflammatory infiltrate in the ulcer base. Then formation of granulation tissue, new small blood vessels which are present. You can see that lined by plump endothelial cells, edema and inflammatory infiltrate are also seen. Fibrotic tissue beneath the ulcer base, all fibrosis. So remember the word digs. I repeat, that is necrotic debris, inflammatory cellular infiltrate, granulation tissue, and S stands for scar formation or fibrosis. Fibrosis in the muscularis propria, and chronic, this is the chronic inflammation marked with C. Now this is the endoscopic view of the bleeding ulcer. Now we come to the another important topic, which is tumors of the stomach. Now tumor of the stomach, what is a polyp? Before we discuss the tumors of the stomach or tumor-like lesions, a polyp is a mass which projects from the mucosal surface of a hollow viscus into the lumen. So mass which is projecting from the mucosal surface of a hollow viscus into its lumen. A polyp may be hyperplastic or neoplastic. Majority of the gastric polyps are hyperplastic and inflammatory, and they are multiple. They are seen around the age of 50 to 60 years, and they are found in association with chronic gastritis. Now this chronic gastritis initiate the injury, which leads to reactive hyperplasia, and growth of the polyp takes place. The risk of dysplasia in inflammatory polyp, it ranges about 1 to 20%, and it is sharply increased in pedunculated polyps and in those polyps which are more than 1 centimeter in diameter. Most inflammatory or hyperplastic polyps are less than 1 centimeter in diameter. Frequently multiple, particularly in individuals with atrophic gastritis. So they are seen in those individuals already suffering from atrophic gastritis. Hyperplastic polyps, they are ovoid in shape and have a smooth surface. Superficial erosions are common in inflammatory polyps. Please note these points, that hyperplastic polyps are ovoid in shape and have a smooth surface. Superficial erosions are common in inflammatory polyps. Microscopically, polyps have irregular, cystically dilated, and elongated foveolar glands. The lamina propria is oedematous, containing variable degree of acute and chronic inflammation. So the polyps, they are composed of irregular, cystically dilated, elongated foveolar glands, the lamina propria is oedematous and there is variable degree of acute and chronic inflammation. Now, benign tumors, when we say that, we refer to gastric adenomas. Gastric adenomas are benign epithelial tumors, 3 times more common in males, seen around 50 to 60 years, sessile or pedunculated, 3 to 4 centimeter in size, found in pyloric antrum as mostly solitary lesions. They are associated with chronic gastritis, especially with atrophic gastritis and intestinal metaplasia. The risk of adenocarcinoma increases when its size is more than 2 centimeters. Now, adenomas, they show dysplasia, and when they show dysplasia, we just grade that dysplasia as low grade or high grade. Both grades of dysplasia, they are characterized by nuclear enlargement, elongation, pseudostratification, and hyperchromasia of the nuclei. High grade dysplasia is marked by severe cytological atypia, and there are architectural abnormalities which includes glandular budding and gland within gland or cribriform structures. Now we are discussing gastric adenomas and their histological types, that is tubular, villous or tubovillous. Okay, we were discussing benign tumors and gastric adenomas. Now we come to gastric carcinomas, and the most important one is in the gastric carcinoma is the adenocarcinoma, which forms 90% of the tumor. It has a worldwide distribution. Commonest type of carcinoma is adenocarcinoma, as I just mentioned, common in men, seen after 30 years of age. Incidence rises after 50 years of age, associated with smoking. Incidence of gastric carcinoma varies in different areas. Higher incidence is seen in Japan, Chile, Costa Rica, and Eastern Europe, whereas its incidence is low North America, Northern Europe, Africa, and Southeast Asia. Etiology: contributing factors are multiple. H. pylori infection, dietary factors such as consumption of smoked fish and meat, pickled vegetables, decreased intake of fresh fruits, vegetables, nitrates in water, use of food preservatives, smoking, alcohol, and then there are certain entities like chronic atrophic gastritis with intestinal metaplasia, pernicious anemia, close relatives, they are at high risk. Peptic ulcer disease is associated with reduced risk of gastric cancer. But on the other hand, partial gastrectomy, which is performed for peptic ulcer disease, is causing the reflux of bile, which ultimately increases the risk of gastric carcinoma in the residual gastric stump, possibly due to low acid level and due to reflux of bile. Now, there are certain conditions which predispose to gastric carcinoma. Again, I repeat, that is chronic atrophic gastritis and then gastric adenomatous polyps. Risk factors, again, patients with chronic atrophic gastritis and intestinal metaplasia post gastrectomy patients, or in those patients where there is persistent gastric inflammation, or in the families which give positive history for gastric carcinoma. They are the risk factors for carcinoma of the stomach, that is adenocarcinoma. Now, if you see this chart, pathogenesis of gastric carcinoma in the fundus and antrum. Initially, there is normal mucosa, then chronic atrophic gastritis, intestinal metaplasia, dysplasia, intramucosal carcinoma, and then invasive carcinoma. Now, regarding the pathogenesis, familial gastric cancer. Familial gastric cancer has strong association with germline loss of function mutations in the tumor suppressive gene, that is CDH1. Loss of function mutation in CDH1 are also present in about half of sporadic diffuse gastric tumors. Now, intestinal type gastric cancers, there are two differences. One is associated with loss of CDH1 function. Intestinal type gastric cancers are strongly associated with mutation that result in increasing signal via the Wnt pathway. So I repeat that intestinal type gastric cancers are strongly associated with mutations that result in increased signaling via the Wnt pathway. And in that, there is loss of function mutations in the APC tumor suppressor gene and gain of function mutations in the gene encoding beta catenin. Now, if we classify, there are many types how we can classify gastric carcinoma. Number one, based on pathogenetic sequence, that is early gastric cancer, when the tumor is confined to mucosa and submucosa. Advanced gastric carcinoma, when the lesion has penetrated the muscular coat. According to location, the tumor arises from gastric antrum in almost in 50% of cases, lesser curvature 40% of cases, greater curvature 12% of cases. One can classify it according to macroscopic patterns. It can present as a polypoidal mass, that is, the tumor is coming out into the cavity of the stomach or projecting into the cavity of the stomach, or ulcerated type, in which the tumor is presenting as an ulcer. Very simple. The tumor is presenting as an ulcer present in the wall of the stomach, and there is a formation of malignant ulcer, and this malignant ulcer has heaped up margin, whereas in peptic ulcer disease the margins were not heaped up. Then Another type, which is flat or depressed type, in this there is no obvious mass within the mucosa. Uncommonly, a broad region of gastric wall or the entire stomach is extensively infiltrated by malignancy. This results in the formation of leather bottle stomach or linitis plastica. I repeat, flat or depressed form. There is no obvious mass formation within the mucosa. Uncommonly, a broad region of the gastric wall or the entire stomach is extensively infiltrated by malignancy. This results in the formation of leather bottle stomach or linitis plastica. Now, in this photograph, you can see carcinoma of the stomach, and also it is shown here. Now, this photograph shows a malignant ulcer, and there is a photograph showing linitis plastica. There is diffuse infiltration of the tumor into the wall of the stomach. Now, microscopic patterns, intestinal type, neoplastic intestinal glands, they are resembling like that of colonic adenocarcinoma. The neoplastic cells may contain apical mucin vacuoles, and mucin may also be present in the lumen of the glands. Very important point that in intestinal type, the tumor resembles like that of colonic adenocarcinoma. That is, the adenocarcinoma of the stomach looks like or resembles like that of colonic adenocarcinoma, and the neoplastic cells contain apical mucin vacuoles, and mucin may be present in the lumen of the glands. Now, tumors which have got intestinal type microscopic patterns, they form bulky masses and are, as I already mentioned, that they are composed of glandular structures, whereas those which are of diffuse type, they infiltrate the wall of the stomach and they do not form big mass. Now, diffuse type, in this pattern, the tumor does not form glands. There is diffuse infiltration of the stomach wall either by small clusters or individual discohesive cells because of the absence of EK adherent. The tumor cells contain large mucin vacuoles that expand the cytoplasm and push the nucleus towards the periphery, creating a signet ring appearance. Now, as I already mentioned, that the intestinal type of cancers or tumors, they show formation of large mass, whereas diffuse type of cancers, they you hardly find mass in it. But these tumors are infiltrative and they evoke a desmoplastic reaction which stiffens the wall of the stomach. Now, once there is large areas of infiltration, in case of this diffuse type, there is flattening of the rugal folds, and this thickened wall imparts a leather bottle appearance which is termed as linitis plastica. Now the microscopic feature, you can say that it's a moderately differentiated gastric adenocarcinoma. These are the tumor glands present here and are infiltrating up to the submucosa. These glands show variation in size and shape. Then high par view of that. These neoplastic, look at the neoplastic glands, and the lining cells show mitosis, increased nuclear cytoplasmic ratio, and there is hyperchromatism, and there is desmoplastic stromal reaction to the infiltrating glands. Now these glands, they are infiltrating. You can say these glands are infiltrating, and here there is a desmoplastic stromal reaction. Now this is the tumor in which you hardly find any glands in it, and it's a poorly differentiated tumor, so the glands are not visible. There are rows of infiltrating neoplastic cells with marked pleomorphism, and many neoplastic cells have clear vacuoles of mucin. Clear vacuoles of mucin. No gland formation. Glands are not visible. Again, as I already mentioned, that a variant of adenocarcinoma of the stomach, which is diffuse type, which is extensive and infiltrative. And here you can see this is the glands formation, normal glands, gastric glands at the top, whereas this is the, here down, there are the signet ring cell adenocarcinoma or signet ring cell seen below. This pattern is typical of the diffuse type of adenocarcinoma. High par view of that. Now you can appreciate this is the arrow pointing towards that mucin is present in the cells, and these mucin is pushing the nucleus towards the periphery, forming a signet ring appearance shown by the arrow. Clinical features: 90% asymptomatic until late in course. They remain asymptomatic, most of the tumors. They can be epigastric pain, anorexia, weight loss, dyspepsia, dysphagia, nausea, vomiting, altered bowel habits, occult blood or occult bleeding, anemia because continuous loss of blood, and mass formation occurs very late. Now regarding the spread, if you can focus it, the four main routes: direct invasion to the adjacent viscera, direct invasion. We're coming to that. Lymphatic spread is the main route, vascular spread and lymphatic spread to the lymph nodes, and then transcoelomic spread, which results in malignant ascites. Local extension, that is local spread or local extension to duodenum, esophagus, pancreas or retroperitoneal tissue. Metastasis to liver, lungs, brain, bones, and then peritoneal seedlings. Then a term used Sister Mary Joseph nodule, which are the metastatic deposits of the tumor in the umbilical or paraumbilical region to form a subcutaneous nodule which is of variable size, and the nodule may be painful and may discharge a fluid. Then formation of varicose node, that is left supraclavicular lymph node, metastasis to left supraclavicular lymph nodes, call it as varicose node. Then Krukenberg tumors, that is bilateral spread to the ovary. These are the, call it as Krukenberg tumor. Poor prognosis, overall 5-year survival rate is in 20% of cases. When the tumor is confined to mucosa and submucosa, or it presents as a polypoidal mass or tumor, 5-year survival rate is seen in 90% of cases. Now, connective tissue tumors, leiomyoma, commonest benign connective tissue tumor, hard, oval, round, intramural nodules covered by intact mucosa project into the cavity about 1 centimeter in diameter. Large tumors may undergo ulceration. Leiomyosarcoma, although rare, stomach is the commonest site to develop this tumor. Submucosal nodule, which attains large size and the surface may ulcerate. Metastasis through blood vessels. Then we come to another important tumor, which is gastrointestinal stomal tumors called GIST. Now, gastrointestinal stomal tumors is the most common mesenchymal tumor of the abdomen. More than half of these tumors, they are found in the stomach, form about 1 to 3% of the gastrointestinal tumors. Cell of origin is interstitial cell of Cajal, which is mesodermally derived cells located in the muscularis propria and function as a pacemaker cell in transmission of stimuli leading to coordinated contraction of smooth muscles. So it arises from interstitial cell of Cajal, which is located in the muscularis propria, acts as a pacemaker cell, which is responsible for coordinating the movement for the contraction of the smooth muscles. Approximately 75% of these gastrointestinal stromal tumors have oncogenic gain of function mutations in the receptor tyrosine kinase. Another 8% of GIST have mutations that activate the related receptor tyrosine kinase, platelet derived growth factor receptor alpha. 75% of them, they have got gain of function mutations, receptor tyrosine kinase. Now, gastrointestinal tumors, they are seen from middle to old age, usually seen around 60 years of age, uncommon in children, more common in male. Some GISTs, that is gastrointestinal stromal tumors, they are related to carnitine, which is a syndrome seen in females, which is gastric GIST, paraganglioma, and pulmonary chondroma. There is also an increased incidence of GIST in individuals with neurofibromatosis type 1. Now, there are many other mutations which are seen in GIST, like mutation in neurofibromatosis, BRAF, HRAS, NRAS, and mutation in genes encoding components of mitochondrial succinate dehydrogenase complex, that is SHDA, SHDB, SHDC, and SHDD. There is also partial or loss of chromosome 9, 14, and 22, and deletion of 9p results in loss of CDNK2A. Now, regarding the gross appearance of the tumor, commonest site is the stomach, and just they are found 40 to 60% cases are present in the stomach, followed by jejunum and ileum 25 to 30%, duodenum 5%, and in the colorectal region 5 to 15%. It may be of any size but may reach up to 30 centimeter in size, usually single, well circumscribed, and present as fleshy mass. Its cut surface is smooth, lobulated, and show whorly appearance. Its location is either submucosal, subserosal, intramural. Now, as I told you that there are two important markers. Now, as I told you, the diagnostic marker is CD117. But now there is another marker which is DOG1. They are used in immunohistochemistry. Now, regarding the microscopic features, there are three types. Either they are spindle cell type or epithelioid type or mixed type. In 70 to 80% of cases, gastrointestinal stromal tumors, they are spindle cell type. You can appreciate it here that they are composed of fascicles or whorls of spindly cells with oval or cigar-shaped nuclei and the eosinophilic cytoplasm, which is shown here. Now, high power view of that, you can appreciate that cigar-shaped nuclei and eosinophilic cytoplasm. Then epithelioid type, 20 to 30%, composed of round or polygonal cells with central nucleus and abundant acidophilic or clear cytoplasm. Now, signs and symptoms, due to the effect of mass, if it is the tumor is large, there can be abdominal pain. Due to blood loss, there is anemia, and blood loss takes place when there is ulceration of the overlying mucosa, spread to liver, peritoneum, or lungs. Metastases appear more than 30 years after the removal of the original tumor. Now, prognosis depends upon the size of the tumor, mitotic rate, location. Tumors less than 2 centimeter in size with mitotic rate less than 5 mitoses per 50 high power field have no risk of recurrence, whereas tumors greater than 5 centimeter in size with mitosis 5 per 50 high power field have more aggressive behavior. Gastric cysts, they are less aggressive than the intestinal cysts. Can be a viva question. Gastric cysts, they are less aggressive as compared to intestinal cysts. So all GIST should be considered potentially malignant, that they have the tendency to undergo malignancy. So no GIST should be correctly classified as benign. Now there are other risk factors, and for GIST, that is, their behavior, as I told you, depend on the size and the number of mitoses, but it also depends upon the presence of necrosis, cellularity, infiltration to the surrounding structure, serosal invasion, and rich vascularity. I have briefly discussed the subject, and if you have any question or you want any clarification regarding the subject, please do write down in the comment box, and inshallah I'll answer that.